Good day, we are Group 5, and today we will be discussing the contents of our synthesis paper with the topic The Effect of Monoamine Oxidase Inhibitors on the Embryo Circulatory System Development during Pre and Perinatal Stages of Pregnant Women.
On impact of maternal actions, women's decisions during pregnancy, including nutrition, stress management, lifestyle choices, and medication use significantly influence the health and growth of the fetus. On prenatal and perinatal challenges, pregnant women undergo physical, hormonal, emotional, and psychological adjustments, emphasizing the importance of factors like prenatal care, a balanced diet, and lifestyle choices. In monoamine oxidase inhibitors, MAOIs, a class of psychiatric drugs treating anxiety and depression, impact neurotransmitters in the brain, potentially influencing the development of the embryo circulatory system. In complex decision making and future research, in navigating these complexities, healthcare professionals engage in informed discussions with pregnant patients, recognizing the evolving understanding of medication interactions, and emphasizing the need for further research to refine guidelines.
In embryonic heart development, the primitive heart tube initiates the first heartbeat around gestational day 22. By the end of the third gestational week, passive oxygen diffusion becomes insufficient, emphasizing the fetal heart's importance. Various progenitor cells contribute to forming the four-chambered heart by the seventh gestational week. Fetal cardiovascular adaptations prioritize delivering highly oxygenated blood to the brain and heart, bypassing the lungs. This involves vasoregulatory agents like prostaglandins and endothelin-1, along with anatomical adjustments, including four shunts: the placenta, ductus venosus, ductus arteriosus, and foramen ovale. Endothelin-1 maintains elevated pulmonary vascular resistance, while prostaglandins shift from vasoconstriction to vasodilation. Fetal circulation relies on the placenta for gas exchange, adjusting by the 10th week of gestation. Despite low placental oxygen pressure, high ventricular output and fetal hemoglobin ensure sufficient oxygen supply. The umbilical vein carries oxygenated blood to the liver, with the ductus venosus bypassing a significant portion. In terms of antidepressant use during pregnancy, monoamine oxidase inhibitors like salicylic, isocarboxacid, phenelzine, and tranylcypromine increase neurotransmitter levels by inhibiting monoamine oxidase activity. Effective for depression, MAUIs require careful consideration of dietary restrictions and potential drug interactions, especially during pre-perinatal and perinatal stages.
For the first part of the discussion, the group will go over the following. First, we have perinatal MAO inhibition produces long-lasting impairment of serotonin function in offspring. Then we have serotonin and cardiovascular diseases. Moving on, we have the prescriber's guide to classic MAO inhibitors for treatment-resistant depression. And lastly, we have the use of prescribed psychotropics during pregnancy, a systematic review of pregnancy, neonatal, and childhood outcomes.
We found that inhibiting both monoamine oxidase A and B results in a significant and enduring decrease in SERT binding, notably during prenatal inhibition. This reduction, observed particularly in the raphe and cortex nucleus, extends beyond the nervous system to affect the formation of the myocardium and endocardial cushions in mouse models. Our findings raise concerns about the long-term consequences of antidepressant drugs and other monoamine oxidase inhibitors, highlighting potential disruptions in serotonin production crucial for normal cardiac structure development in mammals. We recommend a cautious approach to the use of such medications, especially during pregnancy. Studies on monoamine oxidase inhibitors and their impact on serotonin concentrations reveal a complex relationship where both decreases and increases in serotonin impact cardiac morphogenesis. The serotonin transporter, or SERT, is identified as crucial, influencing cardiomyocyte development and early cardiac valve formation. Although monoamine oxidase inhibitors were not mentioned directly, since these types of drugs indirectly disrupt the regulation of serotonin via different pathway, it may be possible that it can also induce cardiac abnormalities in the embryo during cardiac morphogenesis.
In a recent study by Van, the use of monoamine oxidase inhibitor (MAOI) antidepressants, including phenelzine, trancypromine, and isocarboxylid, was explored. Unlike selective serotonin reuptake inhibitors or SSRIs or tricyclic antidepressants or TCAs, MAOIs reduce the breakdown of neurotransmitters such as serotonin, norepinephrine, and dopamine, increasing their levels within and outside the neuron. This contrasts the SSRIs and TCAs, which primarily elevate extracellular neurotransmitter levels. It is crucial to note potential risks during pregnancy. MAOIs can cross placental barriers, posing a potential risk of teratogenic abnormalities in embryos. The article emphasizes that serotonin affected by MAOIs has vasoconstrictive effects. Elevated serotonin levels, particularly during fetal development, may contribute to abnormal constriction of pulmonary arteries, increasing resistance in the pulmonary circulation. Moreover, hypotensive effects of MAOIs may impact maternal blood pressure, influencing fetal blood development and oxygenation. This effect could lead to insufficient nutrient and oxygen supply in a developing fetus, potentially causing developmental abnormalities. Disruptions in maternal blood pressure induced by MAOIs may interfere with the essential balance of oxygen and nutrient exchange in the placenta, crucial for proper fetal growth and organ development. So, in summary, the study underscores the need for careful consideration when prescribing MAOIs, especially during pregnancy, due to their potential impact on neurotransmitter levels and associated risks to fetal development.
The systematic review by Curley and Denton comprehensively explores the impact of psychotropic drugs on pregnancy, neonatal, and childhood outcomes, focusing on mood, anxiety, and sleep disorder medication. The paper acknowledges the challenge of balancing maternal mental health risks with potential medication effects during pregnancy. The study delves into tricyclic antidepressants or TCAs and monoamine oxidase inhibitors or MAOIs, noting limited evidence of TCA tetragenicity. However, recent studies highlight the potential disruption of serotonin system development by antidepressants, leading to lasting behavioral consequences. The paper also addresses serotonin reuptake inhibitors, linking them to an increased risk of preterm birth. Although not directly addressing MAOI's impact on the circulatory system of embryos, it provides essential insights into how these drugs or antidepressants may affect pregnancy outcomes and fetal development, emphasizing the importance of considering potential risks and benefits.
For the second part of the discussion, we have the following. First, we have the association of persistent pulmonary hypertension in infants with the timing and type of antidepressants in utero. Then we have a systematic review and meta-analysis considering the risk for congenital heart defects of antidepressant classes and individual antidepressants. Then we have the antidepressant discontinuation before or during pregnancy and risk of psychiatric emergency in Denmark, a population-based propensity score matched cohort study. And lastly, we have a risk-benefit balance assessment of SSRI antidepressant use during pregnancy and lactation. Studies have suggested a link between increased serotonin levels and persistent pulmonary hypertension in newborns, or PPHN. While most research focuses on selective serotonin reuptake inhibitors, or SSRIs, there are overlaps in mechanisms with monoamine oxidase inhibitors, or MAOIs, raising hypotheses about serotonin's role in PPHN. In a study by Tryon Monk-Olson examining 1,246,347 live-born singleton children, antidepressant exposure during pregnancy was analyzed. PPHN incidence among exposed children was 2.6 per 1,000 live births compared to 1.3 per 1,000 unexposed children. The adjusted odds ratio, or OR, for PPHN after antidepressant exposure at any time during pregnancy was 1.229. So timing mattered, with an OR of 0.8 for less than or equal to 20 weeks gestation and 2.01, which is greater than 20 weeks gestation. Risk varied by antidepressant type, showing an OR of 2.56 for non-SSRI and 1.32 for SSRI. The study highlights a potential link between late pregnancy antidepressant exposure and an elevated PPHN risk, with a relatively low absolute risk. The number of mothers needed to treat for one additional PPHN case ranged widely, emphasizing complexity. So, extending these findings to MAOI warrants careful consideration, urging nuanced investigations into different antidepressant cases or classes, for a comprehensive understanding of their effects on neonatal outcomes.
In a comprehensive meta-analysis, De Vries et al. Examined 5,337,223 pregnancies across 20 studies spanning 14 countries. Their findings reveal a 1.2 to 1.4 times higher likelihood of congenital heart defects when mothers use antidepressants in the initial trimesters. SSRIs, especially citalopram, shows a significant association. SNRIs and SSRIs increase the risk during this critical cardiac development period, while PCAs exhibit no elevated risks. On an individual basis, paroxetine, fluoxetine, sertraline, and bupropion indicate higher probabilities. Overall, antidepressant use increases risk by approximately 1.3 times. This study sheds light on class effects, emphasizing the potential role of various antidepressants and congenital heart defects, offering crucial insights into the developing embryo circulatory and nervous systems.
In the study of antidepressant discontinuation in psychiatric emergencies, a Danish cohort study spanning 1997 to 2016 investigates the impact of stopping antidepressants during pregnancy on the risk of psychiatric emergencies, utilizing psychiatric admissions or emergency room visits as indicators. The findings and recommendations of this study is that discontinuing antidepressants during pregnancy is associated with a notable rise in psychiatric emergencies, emphasizing the potential benefits of maintaining antidepressant treatment throughout pregnancy for minimizing mental health crisis.
In this study done in 2019, it conducted a risk-benefit balance assessment of SSRI antidepressant use during pregnancy and lactation. This literature is about the intricate relationship between selective serotonin reuptake inhibitors and pregnancy, the complexity surrounding the use of these antidepressants in the context of maternal fetal health were discussed in the study. SSRIs, which are recognized pillars in managing major depression, present uncertainties when administered during pregnancy, as outlined by Fisher and colleagues. The related literature unveils a comprehensive overview of the risks tied to SSRIs during pregnancy, spotlighting concerns about fetal development, including the shadows of spontaneous abortions and birth defects. Conflicting narratives emerge within the pages, posing a complex explanation to be able to understand whether the link between SSRIs and spontaneous abortions stems from the treatment or the maternal condition. It should be noted that there is a subtle rise in cardiovascular malformations risk, particularly in the first trimester, challenging our understanding. Beyond the surface, considerations like preterm birth, low birth weight, and complications such as poor adaptation syndrome contribute to a surge in neonatal intensive care unit admissions. Unpacking the impact on neurodevelopment, the literature hints at potential links with autism spectrum disorder and attention deficit hyperactivity disorder or ADHD, extending to influence cognitive, language, and motor outcomes. A cautionary note should be kept in mind, emphasizing the need for a nuanced interpretation of findings and an imperative for ongoing research. The literature reasons out a balanced consideration of benefits and risks, calling for a continued narrative through research to guide evidence-based clinical practices and deepen our understanding of the delicate interplay between SSRIs and maternal fetal health. In conclusion, the use of monoamine oxidase inhibitors in the preperinatal and perinatal stages of pregnancy raises concerns about their impact on the embryo circulatory system. While MAOIs are known for modulating neurotransmitters, their specific effects on embryonic circulation are insufficiently explored. Elevated serotonin levels from MAOI use may disrupt serotonin transport binding, affecting critical cardiac structures in mice. Inhibiting specific serotonin subtypes in experimental mice may lead to cardiac abnormalities and embryonic lethality. Studies on antidepressant use during pregnancy, mainly focusing on SSRIs, suggest links to conditions like persistent pulmonary hypertension in newborns and an increased risk of congenital heart defects. The similarities between MAOIs and other antidepressants underscore the need for more investigation into MAOI's effects on fetal development, particularly circulatory malformations. The complex discourse on the risk-benefit balance assessment in antidepressant use during pregnancy pose challenges for healthcare providers managing maternal mental health while considering fetal impacts. The potential enduring effects of MAOI inhibition on offspring's serotonin function necessitate careful monitoring. As understanding evolves, healthcare providers must engage in nuanced discussions with pregnant patients for informed decision making. Thus, further research is crucial to refine guidelines and enhance clarity on MAOI specific effects on circulatory system development during pregnancy.